Hello, in this video, I'm going to talk about the physiology of diabetes mellitus and the exercise recommendations and guidelines for somebody with diabetes mellitus. So I always refer to it as diabetes mellitus because there's also a condition called diabetes insipidus, which is a condition of antidiuretic hormone and is completely unrelated to blood sugar regulation, which is diabetes mellitus. So first, to understand how our blood sugar regulation goes wrong, it's helpful to understand how it normally should work. So as with all of the functions in our body, we have a normal homeostatic range that we are striving for. So we are always working to achieve homeostasis, so a balance of each function in our bodies. So blood glucose is no different. So we have our range that we are aiming for. And if blood sugar gets too high, we use insulin to try and bring it back to center. And if it gets too low, we use glucagon to bring it back to center. So those are our two hormones of blood sugar regulation that are constantly working opposite one another to always bring us back to that center, back to our homeostasis and blood glucose. So insulin is a hormone produced by the beta cells in the pancreas. And as I mentioned, we secrete it when our blood glucose is going above our goal, our homeostatic target. So we secrete the most insulin when we eat carbohydrates, because carbohydrates, as we break them down, are immediately converted into glucose as we absorb it into the bloodstream. And then we produce kind of a moderate amount in response to protein, because although protein is broken down and absorbed as amino acids, we can easily convert those amino acids into more glucose as needed. So that's called gluconeogenesis, as in producing new glucose. And we can do that from amino acids and also from fatty acids, but not as readily. So we produce secrete kind of a moderate amount of insulin in response to eating proteins. And then we still secrete a little bit of insulin in response to eating fats, but it's the smallest amount compared to our others. So we secrete it as our blood sugar is going up or when we eat food that would or will cause our blood sugar to increase. We also secrete it during parasympathetic states. So our rest and digest, because digestion is part of that. And when we are digesting, we are absorbing nutrients that are likely going to either be glucose or be converted into glucose. So we secrete insulin during those kind of restful states. So when we secrete insulin and it's going through our bloodstream, the number one thing the insulin has to do is it goes around and sort of knocks on the door of all the different cells and tells the cells to take glucose up from the blood. So the cells will then take up that glucose and use it in that cell to use as fuel. So that's the number one task for insulin. But now let's say all the cells have consumed all the glucose that they want, and there's still more glucose in the blood than we want, because now we're not back down to our homeostatic range yet. So when there's excess, then insulin tells the liver to convert that excess glucose into glycogen, which is a storage form of glucose. So the liver, in response to insulin, converts that excess glucose into glycogen, and that glycogen is stored in the liver and in our skeletal muscles throughout the body. Now, let's say all of our glycogen stores are replenished. We have all the glycogen we need, and there's still too much blood glucose. Then insulin tells the liver to convert that excess into fatty acids. Okay, so those fatty acids that the liver produces go into circulation in the blood, and insulin tells the adipocytes, so the cells of our fat tissue, to take up those fatty acids and store them in the form of fat in that fat tissue. So essentially, insulin is responsible for fat tissue growing larger. So for the fat tissue storing more fat, insulin is responsible. So when somebody is trying to lose weight, the goal should be to minimize things that are causing secretion of insulin. Because the more insulin we secrete, the more fat we store. And diabetics who have to take insulin to manage their blood sugar will agree with you. When somebody is taking insulin, that comes with weight gain. And there are different medications for all sorts of different conditions that stimulate secretion of insulin, and those medications all cause weight gain. So like different steroids and things like that, like corticosteroids, will trigger release of insulin, which is why those certain medications cause weight gain. Okay, so when we're trying to lose weight or prevent weight gain, we want to prevent excessive secretion of insulin. So we need insulin because we need to be able to get back to homeostasis. We need to be able to balance our blood glucose. But we want to keep in mind that the more insulin we secrete, the more fat we will tend to store. And that is even true, even if you're not eating carbohydrates. Like let's say you're on a very low carb diet and you're not eating carbohydrates that stimulate insulin secretion. Well, there are, let me think of the word, sugar alcohols. Sugar alcohols, even though they are not carbohydrates, so you are not ingesting glucose, they still have the effect of stimulating insulin secretion. So even if you're not eating carbohydrates, or it's a very, very low number, or only healthy carbohydrates, fruits and vegetables and grains and things, even if you're eating healthy carbohydrates or very, very little, if you are eating like sugar alcohols or other things that still stimulate insulin secretion, then that's still going to cause your adipocytes to take up fatty acids for storage for later. Okay, glucagon has the opposite effect. It's produced by the alpha cells in the pancreas. We secrete it when our blood sugar is getting lower than our desired homeostatic range. And so it has the opposite effect of everything that insulin does. It goes to the liver and says, okay, time to break down glycogen. So it causes the liver and the skeletal muscles to break down glycogen so that we release that stored glucose into the bloodstream to raise the level. And it also tells the adipocytes to release the fatty acids back into the bloodstream. And so our cells, all different kinds of cells, but especially muscle cells, can use lots of different sources of energy. So glucose, fatty acids, ketones, which are a byproduct of fat metabolism. So the liver will produce ketones when it metabolizes fat, and amino acids. So those are all sources of energy that our cells are able to use for fuel. And so we can use all sorts of different nutrients. It doesn't always have to be glucose. So in terms of diabetes mellitus, let's say somebody is eating a lot of carbohydrates frequently. So they're just having a lot of sugars and pastas, starches, things like that in their diet. Every time they're eating those things, they're secreting a lot of insulin. It's a proportionate amount to how much glucose they're absorbing into their bloodstream from their digestion. So at first, it's okay. The cells take up the glucose, the excess is stored as glycogen. Beyond that, it's stored as fat, and it's fine. But let's say somebody's having excessive carbohydrates and they're having excessive insulin secretion. Now the cells at some point are going to say, leave me alone, I've had enough. So if you're knocking on the door of the cells all day long saying, take up more glucose, the cells eventually are going to stop answering the door. They get kind of overwhelmed and they don't answer the door when insulin comes knocking anymore. And that is when you get desensitized to the effects of insulin. Okay, and that's the beginning of type 2 diabetes. Here, let's go on here. So what is diabetes mellitus? So it is a condition of chronically high blood glucose, and that can be caused in a couple different ways, and that's why we get 3 different types of diabetes. So type 1 diabetes is an autoimmune disease. So the immune system is destroying the beta cells that produce insulin, which means you can't produce insulin anymore because the cells that produce it are gone. There's a small percentage of type 1 diabetic patients where it's idiopathic, meaning we don't know where it came from. But that's a very small percentage, and type 1 diabetes is already a small percentage of all diabetics. So it's a very, very small number where it's idiopathic. But someone with type 1 diabetes will require insulin injections or an insulin pump for the rest of their life because they have no ability to produce their own insulin, which is fatal. I'm trying to remember what physician this was, but long time ago, when they first were trying to understand type 1 diabetes and what was happening, it was described as a condition of wasting, where like the body was melting, and they were described as like peeing out their body tissues. Like all of their body tissues were melting, and then they were urinating it out, because that's one of the symptoms in diabetes mellitus is excessive urination, polyuria. So excessive urination, and they're seeing these people who are just wasting down and their bodies are melting, and they were essentially urinating out all of their nutrients in their tissues. So that's type 1 diabetes. Type 2 diabetes mellitus is the much more common type. It's the majority of diabetes cases. And it's considered more of a lifestyle or metabolic disease. And we have significantly more control over developing or controlling this condition. So type 2 diabetes is like what I described, where someone is eating too many carbohydrates and they're secreting all this insulin, and the cells are like, leave me alone, I've had enough glucose. They become desensitized to the insulin, so they no longer take up glucose anymore when insulin is secreted. So that's a problem. Because now over time, if that keeps happening, the cells are desensitized and they no longer respond to insulin. Two things happen. The cells start to starve to death because they're not getting the food that they need. So even though they're saying no more, leave me alone, well, they're going to need more glucose. But now if they're not sensitive to insulin anymore, they're not going to be able to take up the glucose that they need. And then the other thing that happens is the pancreas is saying, well, blood sugar is going up and up and up because the glucose isn't going anywhere. And so the pancreas will secrete more and more insulin, and then it'll sort of burn itself out. It'll sort of like produce so much insulin that it's running out of materials and ability to keep producing so much. And so then the pancreas ends up secreting less insulin than a normal healthy amount. So you get kind of two pieces of diabetes mellitus. Type 2 would be the desensitivity. I don't know if that's really the right word. But the cells are no longer responding to the insulin, and you get the pancreas, which is no longer able to secrete as much insulin because it sort of burned out its ability to secrete so much. So there are different interventions. There are different ways to prevent or control diabetes mellitus. So number one would be dietary intervention and exercise. So somebody with diabetes mellitus has to absolutely be careful about their carbohydrate intake. So they have to be very aware and tracking their carbs, and be aware of the different types of carbohydrates and the effect that they'll have on their blood sugar. So they must be very, very careful. And there are different styles of eating to facilitate that. And then exercise helps significantly because exercise helps make cells more sensitive to insulin, which is a critical component of improving diabetes mellitus, is making the cells more sensitive to insulin. Because if you think about the job of insulin is to get the cells to take up glucose to use for fuel. Well, during exercise, the cells have a greater need for fuel because we're asking them to work and do things, especially our muscle cells. So when we're exercising and there's a greater need for the cells to have more energy, then they become more sensitive to insulin. So exercise can really go a long way in improving diabetes mellitus. So depending on the person, how advanced the condition is, depending on the presentation and everything, some people will require medications to try and help the cells become more sensitive to insulin, and they may require insulin injections if their pancreas is just not producing enough insulin anymore. And then gestational diabetes would occur during pregnancy in somebody who has never had diabetes mellitus before. So somebody who already had type 2 diabetes, they would still be somebody who has type 2 diabetes. But if somebody has no history of diabetes and then has diabetes during pregnancy, then that's gestational diabetes. So during pregnancy, the placenta produces hormones that increase blood glucose. Now, normally, the pancreas doesn't really have a problem with that. It produces insulin and it manages that increase in blood glucose, and it should not be a problem. But in somebody who does not manage it well, so the placenta increases blood glucose and that body, that particular person, is not secreting enough insulin to manage it, then that would be gestational diabetes. So they would have chronically high blood sugar and they'd have difficulty lowering blood sugar, like in response to carbohydrate intake, and that would be gestational. So it concludes once the baby is born, but it puts the mother at much higher risk of gestational diabetes in subsequent pregnancies and in getting type 2 diabetes outside of pregnancy down the road. So the mother is at much greater risk of both of those things going forward. It also can cause some health risks to the baby. But actually, let's just keep going here. All right, so some chronic complications of diabetes mellitus, and this could be type 1 or type 2, but most cases are type 2. But increased blood glucose means increased inflammation. So just having too much glucose in the blood is damaging to the structures where that blood flows. Think about it as a physical thing. There are physical glucose compounds that are going in the blood. And when there's too high a concentration of them, there are too many glucose compounds, then that inflames blood vessels, it damages blood vessels, it inflames and damages nerves and all sorts of other tissues where that blood is going and carrying that glucose. So as a general rule, the smaller and finer and more delicate the structure, the more it might be impaired by and damaged by that excess glucose. So that's where like the retinas are damaged. They're such small, delicate structures. And if that blood sugar is damaging the tiny little capillaries that are feeding the retina, then it can cause blindness. So this whole list of complications that can occur in diabetes mellitus, they're really occurring in response to the physical glucose that is in the blood that is causing structural damage where it's traveling. All right, so exercise recommendations for diabetes mellitus. It is all about making sure that the person can manage their blood sugar and that you're avoiding risk of serious harm during exercise. So you want to, the person should exercise at a time of day that is convenient for them, where they can assess and control their blood glucose to avoid hypoglycemia. So you want to avoid blood sugar getting too low in response to medications or taking insulin, because when we exercise, the cells become more sensitive to insulin. And so if they just took insulin, for example, that could cause a problem. So that brings us to the next point of avoiding peak insulin action. So different types of insulin that the person might be taking will have different peak insulin actions. So like it might be 20 minutes later, 30 minutes later, an hour later. So the person needs to know what kind of insulin they're taking, when is the peak insulin action, and you want to avoid exercising during that time. So we need to find a convenient time of day that's generally good for that person, where we can avoid that peak insulin action and where they have the greatest control over their blood sugar. Avoid exercise when blood glucose control is poor. So if somebody is going through a phase where they are having difficulty controlling their blood sugar, or it's unpredictable for some reason, so maybe they're changing medications, maybe they're changing their dose of insulin, maybe they're changing their style of eating. So whatever they might be doing that could be interfering with their reliable control of blood glucose, skip the workout. It's not worth it, because if they are not reliably controlling their blood glucose, then they could be in danger of a really serious hypoglycemic event, which can be fatal depending on how low it gets and how long it lasts and whether there's any intervention. So just skip the workout. It is not worth it. So you only want this person to work out when they have their blood sugar under reasonable control. Avoid late night exercising if the person's on insulin or oral medications that lower blood glucose, because again, they're going to be more prone to a hypoglycemic event. Adequate hydration is really, really important for everybody, of course, but especially in the case of diabetes mellitus. And it's helpful to find a consistent time of day that the person has the greatest amount of control over their blood sugar, and then exercise during that time each day. So the body can grow accustomed to exercise at that time, and it can be part of their normal hormonal rhythm day to day. So benefits of exercise for diabetes mellitus. As I mentioned, it makes the cells more sensitive to insulin, which is it's the best thing you could possibly do in diabetes mellitus, is lower the carb intake and control the carb intake and make your cells more sensitive. And so exercise is excellent for that, both cardiovascular exercise and strength training. Cardiovascular exercise has even more benefits. So it lowers risk of all-cause mortality, lowers risk of cardiovascular mortality. In somebody who is predisposed toward type 2 diabetes or has pre-diabetes, it'll help prevent or delay the onset. It makes us more sensitive to insulin, so it improves insulin action. It improves fat oxidation and storage, meaning we store less of it. We oxidize more and use it for fuel and store less. And it improves our blood glucose control. And when it comes to cardiovascular exercise for diabetes mellitus, more intensity has a greater effect on blood glucose than more volume of exercise. So like you're better off doing 30 minutes at a higher intensity than an hour at a lower intensity. Now, ideally, over time, you can increase the intensity and the volume over time gradually, but you only want to increase one or the other at a time. So intensity will have a greater effect. So you might want to increase intensity before you increase the total volume. It'll also reduce LDL and systolic blood pressure, which is helpful. Strength training doesn't have all of those same benefits, but it does increase our insulin sensitivity and thus improves our insulin action, our fat oxidation and storage, and our blood glucose control. So follow the standard recommendations for achieving the optimal amount of cardiovascular exercise over the course of the week, and the optimal amount of strength training. Like if you follow the same guidelines as for obesity or heart disease, then that will also have the same benefit for diabetes mellitus. All right, thank you so much for watching, and I'll see you in the next video.